welcome to the Heart of It All. We are thrilled to have Dr. Brian Goldman returning to the podcast today. His latest book, The Casino Shift, is a must-read. One person called it a real-life take on the pit. Today, a lifelong emergency room doctor tells us how the caregiving crisis is affecting ERs. Hey there, I'm Teri Hart, your host of The Heart of It All, a podcast all about caregiving. Dr. Brian Goldman is a treasure. He's a veteran emergency physician, host of CBC Radio's White Coat, Black Art, and the CBC podcast, The Dose. He's the author of 4 Canadian nonfiction bestsellers. His latest, The Casino Shift, unpacks what a shift in the ER looks like for a doctor and their colleagues. I do not think that there is a tougher area of medicine. We know from recent reports from the Canadian Centre for Caregiving Excellence and the Ontario Caregiver Organization that emergency rooms serve so many different roles for caregivers and the people they are responsible for, from actual emergencies to respite and a whole lot in between. With our healthcare system stretched, our long-term care waitlist in the tens of thousands, and unpaid caregivers often being asked to perform crucial medical procedures at home, the emergency room can tell us a lot about where we are at as a country in taking care of some of our most vulnerable. Dr. Brian Goldman, welcome back to the Heart of It All.
I am happy to be here and happy to see you, Teri.
Thanks. Let's start at the beginning. The book is called The Casino Shift. I think that's a new term for a lot of people. What is the casino shift?
A casino shift is a split night shift. So imagine, instead of arriving at 11 o'clock and, 11 p.m. and staying until 7 or 8 and handing over to a day physician, instead you start maybe at 9 or 10 p.m. and run until 3 or 4 a.m. And then another person comes in at 3 or 4 a.m. and stays until 9 or 10 a.m. So you're splitting the night shift. And casino workers have been doing this for a long time. They have to stay alert to make sure that they're not serving customers or counting cards and other jiggery pokery. And this was first developed at the QE2 Health Sciences Center in Halifax. And I can tell you it has prolonged my career. And I think it's a great title for a book.
So much of this book is about examining the current state of the ERs in the country. This podcast is really about caregiving, and we focus a lot on caregiving for seniors in our lives. So I'm really interested in your research, in your conversations for this book, Dr. Goldman. What did you discover about how our aging population is impacting ERs from coast to coast to coast to coast?
Our aging population includes a lot of people. The leading edge of the baby boom generation is now becoming that part of that population. And so the patients that we're seeing are old, like the highest volume of patients we see are seniors. They have all kinds of conditions, from heart disease, diabetes and high blood pressure. They've had strokes. If they've got diabetes, they might have kidney disease. They've got cancer. They are, thanks to modern medicine, they're surviving cancer. It used to be people would have their first heart attack. Guys would have their first heart attack at age 55 or 60, their first stroke at about 68, and they'd be dead by the time they were 73 or 74. Well, that's not the way it works. We see 90-somethings every shift. And some are thriving, but unfortunately, a lot of them are chronically ill, and that's what we see in the emergency department. And they're not the only factor, but they're one of the major factors that are stretching us to the limit. And Teri, to what is relevant to your podcast which is wonderful, and I'm really enjoying it. Not a shift goes like every other patient I see has a caregiver. It's either a spouse. Or it's a middle-aged, a 50, 60, or 70-something child or children, siblings, or it's PSWs, you name it. They're part of the story. They're part of, they're part of the family, and I'm looking after them just as I'm looking after their loved ones.
So you outline in the chapter called The Long Haul. It's spelt HALL, but I think that we could use that word HAUL as well. That some reasons that a patient with dementia may have a problem getting admitted or moved from the ER. And I really thought that this was something that the general population doesn't necessarily understand. So you as a caregiver could take your loved one to the ER, they're living with dementia, and they get in this holding pattern in the ER. What is that holding pattern and why is it happening?
The holding pattern. Okay, so first of all, I see the patient. I do some blood work. I do a CT scan. I size up their situation at home, and for whatever reason they need to be admitted to hospital. Maybe it's pneumonia. We try to send people home with pneumonia, with walking pneumonia. Maybe it's a urinary tract infection. They've got a little bit of a fever. Maybe, more recently it was COVID, and in the winter months it's respiratory infections, or they're dehydrated. And we see some signs that they're not thriving at home. And so we refer them to the internal medicine service and they admit them to hospital. And, you might be forgiven, at least in the past, for thinking that once they get admitted, they'll, the nurses will do a handover. They'll be brought upstairs by elevator on a stretcher, and they'll be taken to a bed on a ward. Well, that happens less and less these days because there just aren't enough open beds in hospital, and this is not a problem that began last week. So, what's going on? Think of the emergency department as a bathtub, and you've got water coming in by a continuous flow, that the faucet, that's the inflow of patients, including those seniors that we're talking about. And the outflow, the drain, is the outflow of patients to the wards. And that outflow needs Drano because, to unclog it, because there aren't enough beds on the wards. And the reasons for that are that, we have, as a society, or not as a society, I guess with the support of voters in our society, we have voted in governments who have systematically cut the bed capacity. And that has to do with the baby boom generation and the fact that the population is continuing to grow. Plus, we have lots of people arriving every year from other countries, and they're becoming citizens. They're becoming permanent residents, and they're entitled to health care, and I think they should be. But the number of beds per capita is now down by anywhere from 50 to about 65 or 70% per capita, compared to, say, 40 years ago. Now, part of the reason for that is same-day surgery. But even with same-day surgery, the number of beds are not commensurate to this older population, people who have complex illnesses where if they need to be admitted, they really need to be admitted to hospital. There's really no alternative. It's a permanent state of surge, a surge of patients. And traditionally, the emergency department has been the surge capacity of the entire healthcare system, and especially the hospitals. And now that surge has been stretched to the point where we're now treating people not just in hallways, but in the waiting room. And, recently there's been a lot of talk about something called chair medicine, where you're treating some of those sick and older patients seated in a chair because there's no bed for them.
I was trying to think of a way to frame this because I I said in the intro, Dr. Goldman, about the tens of thousands of people on waiting lists for long-term care placement.
Yep.
And so we've got that being the kind of end of the pipeline.
Yeah.
If we put emergency rooms in the center of the pipeline and then we put family medicine at the beginning of the pipeline, we have problems in every single joint.
Oh, yeah.
Like
Absolutely. Yeah.
we have so tell me about, is there like, what do we need to solve first?
That's a good question. I think in many respects you have to solve all of those problems. You've got 6 million Canadians who don't have a family doctor or nurse practitioner, and many millions more have one in name. They don't see them very often. They see them for, periodic examinations, but when they have semi-urgent stuff, they can't get an appointment inside of a month. And if you've got a semi-urgent problem, a month is a long time. It can turn into an emergency very quickly if it's unattended. And so, yeah, you have to shore up primary care, but that's something that will take years to do. If you look at the Organization for Economic Cooperation and Development, OECD standards for family doctors, we're right at the bottom of the list of industrialized nations. We're near the bottom of the list when it comes to having adequate primary care. And, we can talk about this if you like. Other countries do it better. Denmark has right now 99.5% of their population has a GP, and they call them GPs there. They don't like to be called GPs in Canada. They're called family doctors here, but they have GPs. Everybody has one, and they see patients next day, same day. They have an hour a day for that's open for walk-ins, for people who have urgent.
People are going to be screaming at this, going, it's because our taxes are too high in Canada. We can't keep doctors here. Or it's because we aren't recognizing the medical professions of people coming to this country, and we're asking them to go back to school. What is Denmark doing that we could learn from?
So Denmark, first of all, and other countries in the European Union graduate many more physicians. And we need to do the same thing. We need to open up way more medical schools, and they are. We have new medical schools that are cropping up right across the country. But you don't open up. First of all, it takes years to open up a new medical school. Now you've got your first class. Your freshman class. It's going to be a minimum of 6 years before they're out in the community serving patients. So whatever solution you put in place today that involves training more physicians, it's going to take years to have an impact on the population. Can nurse practitioners help make a difference? Yeah, they can. But the first thing is you need more providers, and Canada is taking steps to grow more providers and also to qualify more providers from other countries. Donald Trump and MAGA has created a bonanza of professionals, health professionals from the United States who are clamoring to come to Canada. And what Canada can do is open up the floodgates. What they can do is they can drop a lot of the protectionist type of roadblocks that make it difficult for people to qualify. And the government is starting to listen. They have, I hear that 1,000 nurses from the United States are moving into British Columbia because they have really made things easier over there. So that's one thing that Denmark is doing. They have more healthcare providers, and they're able to put them into service on a continuous basis. The second thing they do in Denmark is to put their family doctors, who are very well paid, on salary. And they seem to be happy with their compensation. They don't see themselves as Canadian family doctors do, as entrepreneurs who have to grow their patient population in order to make more money, but they don't want to do that because the paperwork they have to do is onerous. So that's the second thing that Denmark does. By putting people on salary, by putting family doctors on salary, you eliminate that kind of need to try to calibrate your practice and make enough money as an independent business person. That's the second thing. The third thing that they do is they have elevated teamwork into something more than a slogan. Teamwork in a family doctor's office in Denmark consists of family doctors, learners, residents, nurses, physiotherapists. They use midwives in a really imaginative way. Midwives don't just do prenatal and immediate postnatal care. They do routine gynecology. So they're doing pap smears, for instance, in the office. And they have well baby care. They're doing well baby and a bit of and beyond, and some pediatric care as well. And whereas in Canada, Canadian physicians feel the need to kind of protect their turf. They don't want to delegate to others because they're afraid that the money's going to go with them. Well, in Denmark, it doesn't matter. They're paid on salary. Now, the other thing that they have, which is very pertinent to our conversation here, is superb after hours care. So you don't call the, in Copenhagen, doctor's office and be told, if this is an emergency, go to the emergency department. In fact, this will blow your mind, Teri. You cannot, if you are a patient, you're listening to this conversation right now, you cannot select the emergency department as your preferred destination, as many people do here in Canada out of necessity. You have a GP, you must call your GP, and after hours, you're connected with a call center, which is staffed by GPs who are on call. They will take your history and figure out what you need. If you need a prescription, they'll phone it in. If you can wait to your GP, your own GP the next day, they'll tell you to do that. If they think you have an emergency, they will call an ambulance, or they will say, you go to the emergency department. I have booked an appointment with the ER. An appointment with the ER. So but you see all the things you need to do. And, you talked about taxes, that Canadians are overtaxed, and that's that's the reason why physicians are leaving. That's nonsense. Well, I mean, we have an inefficient system, but the idea that we are overtaxed and is ridiculous. And other countries in the EU have a much higher tax base than we do.
How much is the medical profession behind the times in being able to serve the population? And this is from having doctors in the field, utilizing nurse practitioners and physician's assistants, and expanding hours of family doctors or GPs.
Oh, I think we're way behind the times. I don't think, it has been said, this is kind of cynical, but it's been said that the true client of the Canadian healthcare system is the physician, not the patient and not their family. It's the physician. We're one of the most sparsely populated countries in the world, and we're behind the EU and South Africa and other countries in developing, wilderness medicine, a first response physician who can go out into the field, which is what Nick Sparrow does. So what's stopping us from doing that? Again, it's resources. And, the last chapter of my book is all about that adult conversation that I think you and I and all Canadians need to have about the role of private medicine. And it's here. It's going to get a lot bigger. And we have to look for infusions of money. If the taxpayer can't support the entire healthcare budget, and it's enormous as it is, then we need to look for other sources of revenue.
Full transparency, as a Canadian and as somebody whose mom is now a retired nurse, that scares the heck out of me. Why do you think, what is it about the psychology of Canadians? And I think a lot of people fall into my category of knowing we have a problem, wanting to see an improvement, but this idea of two-tier or private scares us. What am I missing? Educate me.
Well, I think part of it is it has become kind of hardened or fossilized into a kind of trope. It's a gotcha. It's a gotcha thing for politicians. There are limitations in in Canada's healthcare system that would make a private pay parallel system very bad for the public system.
Is the idea that the people going to the private, then, to use your earlier term, they are the Drano of the system that is allowing a flow to happen? Like, is that what the overall sense of a hybrid, a two-tier system, was that what it would accomplish?
Any country that has public and private will have a two-tier system. The better question is, how different are the two tiers?
Mm.
If the difference between the top tier, the private tier and the public tier is a cushier hospital room with a better view, well, who cares? In the same way that do you have to fly business class, or is it perfectly adequate for you to be in the back of the plane? That's a decision. That's a discretionary decision. The question, but if the tiers are so different that you can get life-saving treatment in the private system that you can't get in the public system, then we have a problem. And it brings us to the other reason why we're alarmed by two-tier. We look at what's going on in the United States. We know that the number one cause of personal bankruptcy in the United States is a major health crisis that requires tens of thousands of maybe $100,000, $200,000 worth of hospital care. You're mortgaging the house, and it's a poop show. And it would be quite natural for Canadians to look at the United States and say, hell no, we don't want anything like that. Anything that moves us in that direction, we don't want. And we have a right in Canada to be concerned and suspicious. The other thing is the difference between Germany, for instance, and Canada, in terms of their private and public, is that in Germany, they have more than adequate number of GPs, specialists, nurses, etc., who, if they choose to move from the public to the private system, there's plenty more to come in who are just as qualified. In Canada, we don't have that. So that means that today, if you suddenly built a private system with better hours and better pay, you would see a net flight of doctors and nurses from that system to the private system, and it would impoverish the public system. And so that would widen the two tiers. There's no question about that. You've got to fix both problems at the same time. You've got to walk and chew gum at the same time. Otherwise, this will be a disaster.
Chapter on the ER's closing gave me chills. It is so upsetting. It's one of the most upsetting chapters for me. It is happening in smaller communities first. I want to emphasize first, because it's not like it's not necessarily going to happen elsewhere. And these smaller communities also tend to be where our seniors are living, where people go to retire. So what are you hearing from people in these communities and your colleagues about these ER shutdowns in these smaller communities and the impact that it's having on people in those communities?
20 years ago, a hospital closing was a never event. It was never supposed to happen. Fast forward to today, and we keep stats on it. The reality today is for people who live in smaller communities. Many of them are retirees. I've been to Prince Edward County recently, to Picton. It's a highly desirable retirement type of community. Lots of culture and a reasonably functioning hospital. They're going to build a new one there in the next 2 years. But many smaller communities are one physician or one nurse away from having to close for hours at a time. And maybe it's evenings or nights over the weekend. In some cases, it's longer periods of time. And that means for the people who live in those communities, why do they move? What are the factors that make people want to move to those communities? Well, at or near the top of the list is a nearby hospital and doctors. And if they don't have them, or if they had them, let's go here. They moved there, and now the system's in jeopardy for them. Well, now they've moved there, and so they've got to hope and pray that they don't get sick, or that whatever problems they have are of a non-emergent nature, meaning calling 911, dropping everything, and we got to go there. Or driving, many more kilometers to the next emergency department that happens to be open, and that's the reality. for the people who live in those communities and the people who've lived there for a long, long time. The other thing, Teri, that I really want to mention here that I mentioned in the book is that having a hospital that's fully staffed is not just an attraction for patients, it's an attraction for GPs. You take that hospital out of commission, put it in jeopardy, and now GPs don't want to move there. If they don't want to move there, that means that the next family doctor who retires or dies or moves away is going to make it even harder for people in that community to have primary care.
Everything that you say, and I hope that people are picking up what you're throwing down here, is that everything is a domino effect. And the domino gets harder and bigger with each fall. And it's amazing to me, I can place myself in so many of these situations. My mom and dad moved from Brampton, a very, very significant suburb of Toronto, and they moved to first Thornbury and then Meaford. And one of the first things out of my mouth when they were making that move was, "What are you going to do for a family doctor?" And they were very lucky. They got a family doctor. He's an amazing family doctor. My dad went through the last year of his life with really amazing care, not only at the Owen Sound Hospital, but then he actually died at the Meaford Hospital, which proved to me in real time the importance, the devastating importance of community hospitals. If they didn't have that Meaford Hospital and we had to drive from Meaford to Owen Sound to see my dad every day in the last weeks of his life, Dr. Goldman, I would still be haunted by that because we wouldn't have been able to be there in the way that we were. And there seems to be a very large disconnect between the bureaucrats who are making these decisions about, you know, oh, we can just send these people to a bigger hospital. We're going to build like a wonderful hospital in Owen Sound and it's going to serve this huge community. And not understanding that the geography actually matters in people's lives. And when their caregivers are other seniors or are driving or it's the snow belt or all of the things that we deal with in this country, this is a significant impact on people's lives at their most vulnerable. And I'm sure people can hear how passionate I am about this because I lived it.
And Teri, let me add something to that, to what you've just said. In those last days or those critical times in that person, in that patient's life, if that patient is admitted to a hospital that's 100 kilometers from their home, that means that because family is traveling back and forth, they can't all afford to kind of check into a hotel room. That itself is bankrupting for a lot of families. Then that means they're not there at the bedside when critical decisions are being made. And there's actually data to show that people do better when they are admitted to a hospital as close to home as possible, not far away. So, the bean counters in the Ministry of Finance, in the provincial Ministry of Finance, who are thinking we've got to close down these expensive to run little hospitals, need to keep that in mind, that people do better when their care is delivered the closest to home as possible.
You mentioned about the staffing of these hospitals, and Dr. Drummond, who is a character in the book and sounds like a real character in real life, by the way. He was a delight to read about. I loved how you framed him for us as the reader of The Casino Shift. He said, pointed out that so much of this institutions or politicians are blaming on the pandemic, and he was just like, "Let me get this straight for you. This is not a pandemic situation." And you kind of intimated that this is decades in the works.
Yeah, decades. The cutting of fat from the system has reached the point where they started cutting bone, cutting muscle, vital organs. We don't have enough beds for the population, for the needs of the population that we have, and the needs are growing. And it's not just, by the way, it's not just where Dr. Al Drummond practices in Perth, Ontario. Edmonton, which is a major city in Western Canada, has not had a new hospital built in 40 years. What's that about? I mean, that's crazy. And there are not enough long-term care beds. which means that people who need to be transferred from hospital to long-term care sit and occupy acute care beds for months and sometimes even a year or two while they're waiting for a long-term care bed. We also don't have, if you're going to cut hospital beds per capita, you better have great home care. You better have great community resources so that you can treat somebody at home as if they're in hospital with something approaching the same acute level of care. You need enough people to do that. Teri, we actually have a system where people can qualify for 20 hours a week of home care, personal support workers, etc., but they can't get 10 hours because there aren't enough personal support workers to meet the needs of the home care system. So it's, we talked a while back about dominoes, and I mean, that's another domino. That's another essential piece of the system. You need adequate long-term care beds. You need adequate hospital beds, great home care that allows people to be discharged as quickly as possible and maybe even intercepted from being admitted. I mean, there are hospitals. St. Mary's Hospital in Montreal does a great job, like a SWAT team that identifies people who could potentially go home if they have the right resources that are marshaled in a short period of time.
You talk about needing long-term care beds. You talk about needing better access to personal support workers and an efficient home care system. What is the government doing for our baby boomers who, at the top of the boomers right now, are entering their eighth decade? They're 80.
Well, certainly they're not doing enough. The provinces are not doing enough to meet the needs of the baby boom population as it enters its older elderly years. It's because we don't have enough beds, enough long-term care beds, enough personal support workers that you can begin to see that as that leading edge of the baby boom gets into their eighth and eventually their ninth decades of life, they're not aging as well as their parents did. Just the product of living longer means that by definition, you're not necessarily going to live well right to your last day. And the cynic in me says that to some extent, the provinces are simply waiting for the baby boom to die. Because on the other side, that's a hump. And on the other side of the hump, you'll have what we're having, in our education system where schools are being decommissioned because they're not necessary. And I guess the other thing that we have to think about in our population is what is our attitude towards immigration? Because, if we have this idea that immigrants are bad, if we kind of shut the spigot of the inflow of new Canadians, then we're only going to exacerbate the funding issues that are happening in the healthcare system right now.
More and more people are being sent home in the care of their family or their loved ones who aren't medical professionals, but are being asked to do certain medical procedures. Whether it be change dressings, whether it be manage medications. There's so many other things, Dr. Goldman, that untrained caregivers, unpaid caregivers are being asked to do.
That's right.
I
Yeah.
wonder, how much do doctors, how much do paid caregivers, medical professionals, how much are you talking amongst yourselves about, like, holy geez, I hope this goes okay once they get in that door at their home?
Well, as an emerged physician, we talk about it all the time. We are increasingly burdening caregivers. We're burdening spouses and adult children who have to take time off work. Spouses who, at a time when their own capacity may be limited or diminishing, expecting them to do more. I think about my late father who spent, 15 years of his retirement, his golden years, looking after my mom who had dementia. And he did it to the detriment of his own health. We are increasingly asking loved ones, unpaid caregivers, to look after their loved ones. And, they're terrified. They're terrified that they're going to do something wrong. Or we are asking them to do one more thing. It's always one more thing. Oh, you can do this. It's just one more thing. We want to quickly teach them to do something so that we don't have to come in as often. We meaning, home care services, or there aren't enough home care services, or they're facing a revolving door of different providers. And instead of the home care nurse arriving at 10 or PSW arriving at 10, they arrive at 2. And there goes your day or your opportunity to go out and do a little bit of grocery shopping and bring it back home. Don't get me started. I understand, the issues and the burdens that you're talking about.
Um, and thank you for understanding it. Your ultrasound probe, your portable ultrasound probe is like a character unto itself in your book.
Please wait 1 second. You'll understand. I'll be right back.
Okay, now you're back. What do you have to show us?
Okay, there it is.
Oh my
There's
gosh.
your ultrasound probe.
What's it
Okay.
called?
It's a Butterfly IQ. Now, it's not a shameless plug. I have no shares in the company. It's an ultrasound probe. You connect it to your smartphone. So this one has a lightning cable, that fits into my iPhone. You can get a USB one with a USB-C. It's a universal probe, which means that it will, all you have to do is change the settings on the app, and it will allow you to peer inside your heart, your lungs. You can see if you've got a pneumothorax. It can peer into your belly to see if you've got blood in your belly, which would be a sign of trauma or fluid. I can see if a woman has an ectopic pregnancy or a pregnancy inside the womb. You can check for fractures. So yeah, that's part of the tech. There it is. And because it's so lightweight and so portable, so basically it's beaming images to my smartphone. And it's part of the technological revolution in emergency medicine.
How do you see technology impacting all of these problems that we have?
Good and bad, but let's start with the good. Anything that a doctor can look at and make a diagnosis based on what they see can be done probably better by AI. So if you can develop a technology that captures the image, if it faithfully captures the image, then you can send that image to AI, and it will tell you what you're looking at. And we're just at the beginning of that. AI will almost undoubtedly do a better job of telling you whether you've got cancer, what the grade is, and the molecular testing to get the genetic fingerprint of the cancer. That's something that's already being done. So AI will help people get diagnosis faster. And I will suggest to you that we're not far from the day when, instead of this, there will be an adhesive, a stick-on ultrasound probe that you can connect to your smartphone that will capture the image and send it to an AI algorithm will tell you exactly what's wrong with you. Not now, maybe 10 years, not that far into the future. And that will enhance our ability to diagnose people in a hurry and maybe get them into treatment faster.
Knowing that this is all coming, what are we giving up? Where is the, teeter-totter here?
Well, is the human side of medicine, of diagnosis, empathy, are they important, or in the words of Elon Musk, is empathy dead? It's not dead. We need it. What does empathy give us? It gives us imagination. You need imagination to create new solutions. You need imagination to come up with an inspirational diagnosis. You need imagination to hear something in therapy, as a therapist, that a patient says that reminds them of another patient or reminds them of something the patient said before, which indicates that they're shifting their perspective, that they're moving along in therapy, somebody who can comment on that. We also need human beings to protect us from the dangers of AI. I don't know how much time you're spending on thinking about the fact that young people are turning to AI counselors online. and with detrimental results. There's something called AI psychosis. It's not a real diagnosis, but it's somebody who's developing delusions of persecution or delusions of grandeur, like a thought disorder. And while receiving counseling advice from an AI algorithm, from a chatbot, from Claude or for Chat GPT. And the problem that with AI algorithms is that they are designed to agree with you, and by agreeing with you, suck you in and keep the conversation going. You need to have guardrails, and only human beings can provide the guardrails that we need to truly protect people.
What is the percentage roughly that you would say is the number of seniors that you are seeing in the ER? Is it 50% of patients? Is it 70% of patients being seniors?
Well, yeah, I would say it's 50%, but remember, we're also seeing, younger people who have cancer. We're
Bad things
seeing
happen to younger people too. That's one of your chapters.
20 or 30 somethings who have stage 4 cancer, don't have primary care, and only come to the emergency department when they're really sick. We have people who, because they don't have family doctors, and it's not just cancer. We're seeing lots of people who don't have family doctors who come to the emergency department because they don't have the guiding hand of a family doctor. If you don't have that, then you come to the emergency department where you talk to a stranger like me who has to try to dig that out.
What would you say are some of the frustrations that you and your colleagues see for caregivers bringing their person into the ER?
I think their top frustration is that they're being asked to do too much, to monitor too much. Um, you know, that they're trying to manage the fact that their loved one is taking 15 medications and has too many appointments and can't get them to all these appointments. Maybe they're not, if they're old enough, maybe they're not driving themselves, and so they don't have ready access to transportation. If it's a middle-aged caregiver, they have to take time off work, and their lives are increasingly enveloped in looking after their loved one, and it's diminishing the quality of their own life, that they are postponing their own health needs, putting them to the side to look after their loved one. That there is a joy in life that's getting sucked out of their lives. I think those are the major things. There's practical things, and then there's emotional factors. Those are at the top of the list.
Thank you for sharing that. I think that anybody who has been a caregiver is listening to that and saying, yes, 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 yes. You mentioned your sister, you mentioned your own experience with being a caregiver. We had you on this podcast, one of our first guests, talking about your experience being the primary caregiver for your sister. And I asked you in that interview how it changed you as a doctor. And you told me in that interview that it allowed you to understand caregivers differently, that it created an empathy in you that you didn't think was necessarily absent before, but it certainly opened up a neural pathway that maybe you didn't have in the same way before becoming a caregiver. So I'm interested, Dr. Goldman, for your other colleagues who have not been in the position of being a caregiver in their own personal lives, how do you share that experience with them to look at caregivers differently in the ER?
There's a moment of opportunity to do that, and that opportunity, that crack in the doorway occurs at as they have their first crisis, as a family caregiver themselves. I can tell them, "You're not alone. It's tough, but you'll get through it. We're here to support you." And you know, if they haven't gone through that crisis yet, you know, I I have to tell you, Terry, until I experienced it, I had no idea what it was like, and I don't expect them to know what it's like, unless they had to deal with a crisis at a much younger age, and I'm sorry if they had to. They're allowed to live their lives, and not feel like this is coming until it happens, until it actually happens. But, um, you know, all the telling and talking in the world won't change their perspective as much as trying to inspire them by my example, how I empathize with those family caregivers. I model that. The nice thing about empathy is that it doesn't cost money. It's an infinitely renewable resource. If you extend it, it comes back to you tenfold, and it just makes the place a happier place. It just makes people feel more grounded. The other thing that I try to show by example is to learn the stories of our patients. Just sit and let them talk and learn from them and share with them, so that you build that human connection that makes it so much easier for people to follow your advice, to know that you care.
Ain't no AI gonna beat Dr. Goldman, I'll tell you that.
Or Teri Hart.
Um, we're gonna do this again. Inevitably, I will have some big thing that I need to help figure out in this system, in this medical community. And please don't ever stop advocating. My goodness, we need you so desperately. Thanks so much for being here.
Thanks for doing what you do.
Oh my goodness, Dr. Brian Goldman continues to do amazing work at helping us to understand how our healthcare system is working and where we are heading. I highly recommend his book, The Casino Shift. It's a spectacular read. I hope you are following us wherever you are listening to this podcast. Just give us a follow or subscribe so you do not miss an episode. Our socials are turning into a fabulous community full of great chats. You can find us at the Hart of It All Pod. That's HART. Huge love to my co-producers, Jess and Carrie from 6 of 1 Digital. This podcast simply does not happen without them, or frankly, without you listening and watching each and every week. Thanks so very much, and please take care. I said it in the intro, but it bears repeating that one of the reviews of Dr. Brian Goldman's book, The Casino Shift, said it's like a real-life reenactment of The Pit. So, of course, this week's recommendation is The Pit Season 1 and Season 2. There are all kinds of caregiving stories in there. And we spoke to the showrunner and creator, R. Scott Gemmell, right here on The Hart of It All. Watch the show. Listen to that episode of The Hart of It All. It's a great kind of 1-2 punch. I hope you enjoy it.